I'm particularly excited about this session because Dr. Evan Lewis, who's truly a leader in the space, is going to do something a little bit different. So I really encourage everyone to put their phones away and engage with the content. You all will be a part of what we're doing today, and hopefully it can lead to better dosing, titration, and prescription. This practical workshop is led by Dr. Evan Lewis. If you all don't know him, he is a neurologist and clinical neurophysiologist with appointments at the Hospital for Sick Children and the University of Toronto. We have been fortunate to witness over the years the impact that Dr. Lewis has made on patient lives. His willingness to listen, to stay open-minded, and to have a true impact on patient lives is what he does every day. He has an extensive experience prescribing medical cannabis across adult and pediatric populations, particularly in neurological conditions including epilepsy, chronic headache, concussion, and functional neurological disorder. His work focuses on helping clinicians move from theory to practical, evidence-informed decision-making. Through his innovations, he has been able to build robust data capturing in his clinic work that has enabled him to create dosing and titration guidelines based on clinical experience. Today's workshop will focus on initiation, titration, product selection, safety, and patient management. Please welcome Dr. Evan Lewis.
Okay. Hi, everybody. Thanks for the nice welcome. I'm going to just reverse what Carolina said. Bring out your phones. You're going to need them for the session, so feel free to take them out. This is going to be, it's going to be an interactive, case-based type of discussion where we're going to work through patient cases. So you're going to work as a team, and I'll show you everything how we're going to walk through this. So quickly, as an introduction, we're going to just quickly test everybody's knowledge. So again, get those phones ready. Then we're going to work through a case together on a pediatric condition, anxiety in the context of autism. Then we're going to move to an adult headache case, a sleep case, bring everything together. Hopefully we can do this in the hour. Might be a bit rushed at one point, but don't worry, just getting through the content and the ideas is really what I want to do here today with everybody, to just show how you can protocolize this process. And I'm taking an even harder line on cannabis as I've kind of worked through it. It must be protocolized. It must be standardized if we really want to bring this widely to the medicine field in a way that's safe and effective for patients. Okay, so first off, you've got a packet on your table. So you should see in the center of your table, you've got one there. Everyone is going to join Slido. I'm going to show the QR code in a second. And everyone individually is going to take the pre and post test. All right. One thing, Frank, if you're out there, I just need you to kind of get a sense of the answers from the pre-test. If someone can jot them down, that would be helpful. I'll note when that happens. And then we're going to do the cases in a team-based manner. Okay. So sounds a bit complicated, but don't worry. As I said, I'll walk everybody through it. And one thing just to know, the answers to all the cases are going to be derived from the textbook down there, and I'm going to talk a little bit about that textbook that we recently published. Okay? So again, you have that table packet. It's on your table. So you're going to be used to kind of write answers down. So right now, everybody kind of get your packet together, talk with each other, come up with a team name, designate one person's going to be the spokesperson. So that person's going to be the person who answers on their phone for the table. All right? Everybody else is going to have the individual answers. Another person at the table, so designate someone that's spokesperson. That person's going to enter the team name. The other person at the table, or anybody who wants to, take that QR code, download that resource package. That's going to have all the dosing tables, and that's where the answers are going to be. So you're going to want to grab that. Okay, it's the samples of chapters from the textbook that are relevant to the process for today. So I'll leave that up there for just a moment. Okay, when your table has downloaded resource package, assigned a spokesperson, and you come up with a name, just quickly raise your hand so I can see. All right. You got a name? Okay. All right. Everybody, at least one person's grabbed the resource package and is working? Okay. Okay. All right. If we need to go back to that resource package, let me know. Okay. All right. There's the QR code to join Slido. So again, everybody joins because you're all going to answer the pre and post test questions. But remember, the spokesperson is going to be the one person who's going to answer when we go to the team answers. And I'll let you know which one are individual, which one are team. Okay? Somebody grab that. It should be pretty easy to sign up. You're not going to enter a team name right away. Okay? That won't happen until you're prompted. So don't worry if it's not asking you for that yet. Okay? All right. Okay, so very quickly, just when you're using Slido, what you're going to see when the question pops up, it's going to be multiple choice. It'll pop up automatically on your phone. You don't need to change anything if you've never used this app before. It's actually really good. And then just remember, if sometimes there'll be too many answers or too long, you have to slide them up to get to that send button. So your answer is not sent until you press send, and then it becomes sent. So just know that your answer is not going to be logged until that happens. Okay? Another piece here is at the top has Q&A. There's one little tab for Q&A, one tab for polls. It will automatically switch back and forth. You don't need to touch that. But at any moment in the lecture, you do want to pose a question, you can tap that Q&A and type a question at any time, and it will pop up. It'll bank all the questions, so we'll have the questions banked. So if you've got a big question in the moment, don't worry about it. Just put it in the question and answer, and we'll hopefully get to it. Okay? It's great. I feel like I'm in school right now doing all this. It must be. Yeah, being a teacher is tough. I feel for them right now. Okay. All right. So we're ready. Here's the 3 questions before we start. Okay. So remember, everybody, this is you're answering on your own here. Okay. So everyone should respond on their phones or their device. And here we go. Okay. So the first question is, okay, so for a patient who's interested in trying medical cannabis for headache, what approach should be taken if they have a chronic daily headache with mild to moderate severity? Okay. So this is where any helpers out there, so Frank or any of the other helpers, once the answers come up, if you could just snap a shot of the screen of the results. Okay. Okay, so that's one question. And as you scroll down, there should be more questions. So the other question is this: when weaning a patient off a THC-dominant oil used for sleep after concussion, what is the main risk to anticipate? So remember to press send, okay? And again, these answers are on your phone. You just scroll down. All 3 should be there. The third question we're looking at is for a child with anxiety and autism spectrum disorder, which initiating approach fits the best evidence? Okay, there's all your possible answers. Okay, so okay. Is anybody having trouble? Is it okay? So remember, if you scroll all the way down, there's going to be a send button. So once you're done, you've logged your answers, make sure to press send. Okay? You don't need to resend it once you've sent it. Okay? Okay. All right. So we're going to come back up here. So this is the first question. Can someone just take a screenshot of that at the back? There we go. Thanks, helper. So we'll remember. So what we have for this question, everybody remembers, the leading answer is a CBD oil with non-significant THC, either an isolate, broad, or full spectrum. And then we have a variable number of answers down there. And good, a good portion is not sure. Okay? So we're going to stop the answers right now. The 2 participants responding. Okay, here's the distribution for the second question. Very good. Someone can take a picture of that so we know for the end. Thank you. And here's the last one. Okay. All right. Good. Okay, so I'm going to quickly just talk about dosing. As Carolina's mentioned, I've been treating people with cannabis for over a decade now. I can't believe I'm actually saying I can use that word, over a decade at this point. But thousands of patients, both pediatric and adult, and it's in the time that I've done this, from the lens of a neurologist and medical doctor, it certainly has gone through its phases. The initial phase was, oh my God, what are we doing here? And everybody was hands off, right? And that was a pretty scary time, coming at this. And you had to be pretty sure of yourself. But I think we've kind of moved past that in general. And then it came to like, well, what do I do? How do I get this? This is too difficult. And then there was and it continues to be the era of every single little minor cannabinoid can do this, and that happens for 6 months. THCA is good for X, and CBG is good for this, and it went through its phases. And I think we're getting really good research in the minor cannabinoids now that's flushing that out. It's come to this point now where I really truly believe that we have enough doctors, enough clinicians, enough nurses, enough people who are willing to prescribe or authorize as they're seeing the data in certain conditions, and they kind of know how to get it, they just don't know what to do. And it's the dosing, and that freezes people, and it's a massive barrier that I'm seeing now with my colleagues and seeing with everybody else, and I think we're really missing it. So this is kind of why, in some degree that I think, very simplistically, if we think of drugs in the traditional pharma pathway, the dose determination is decided way before it's put into humans, and then it's just kind of tweaked along the way. So by the time that drug comes to market, you're following a recipe book. It's so simple for doctors. It's so simple for nurse practitioners, pharmacists to dispense. You just open up a guide or you go online and you're told step by step what to do. Okay? So it's not even a thought, right? Even more so, drug reps come to you and they tell you what to dose, right? And you just, sometimes you say, okay, that sounds reasonable. You look at the evidence and say, okay, that makes sense. Cannabis, though, has come from the grassroots. It came up from the patients. It came up from people doing a variety of different things in a flower that has over 120 different compounds plus, right? So what do you do? And so really, we're just trying to organize through the chaos of this, and I feel like that's what I've been doing since day one, but I think I recognized that very early, and I created very strict protocols very early that I started to use in my patients. And so I think this is where you get this kind of difference along the pathway. And when you go to the evidence, it is reflected there. Okay, so this is one of the most, I think this is a systematic review that published in 2022 that's quite telling. I looked at something, 55 studies, okay? Look at the range of THC dosing, 0.01 to 0.5 milligrams per kilogram per day. If you do the math on that, right, you're talking 10 times doses here in conditions, right? Look at the range of CBD dosing. It's enormous, okay? So obviously what you're going to do when you then do meta-analyses and further systematic reviews, what ultimately is going to be concluded? It's going to be concluded what happened earlier this year. I don't know if anybody, you remember this came out. This made a lot of news, this article. And essentially it was a big systematic review and meta-analysis that basically said routine use of cannabinoids for mental disorders, substance use disorders is currently rarely justified. And this made news all over the UK, it made news here, basically saying cannabis is no good, and then concluding cannabis is not good for these conditions. And that extrapolates, well, if it's not good for these conditions, how can it possibly be good for any other conditions, right? And this narrative then starts to build, okay, and it's really problematic. Go look at the studies that they looked at. Look at the variability in dosing. It's enormous. Of course, this is the conclusion. You have no consistency here. Right? So this is where I think we really need to take the space. Right? And that's kind of the purpose of this workshop a bit, to introduce that. It was also drove the rationale with myself leading the charge with the Medical Cannabis Clinicians Society in the United Kingdom, which I've been a member of since 2018, for us to publish the first standardized medical cannabis oils guidebook. What's in this book? Okay, so the book has an introductory part, a part one that kind of teaches to some of the principles. That's the text-based version, a lot of the pharmacokinetics, the interactions. But then the second part of the book is where it's important. Second part of the book is indication specific. And we picked 12 indications total and kind of also looked at kind of just general titration and weaning and protocolized each and every one of these. Right? How do we protocolize them? We did this. Based on research, real-world evidence, and expert opinion. Okay, so ultimately, in the end, we had over 194 citations plus other kind of minor citations. I personally, with my practice and what we did, with the help of Frank, who's here today, we did a chart review of over 500 patients, of which we published a small subset of that and are publishing currently another subset now. So that informed the dosing approach as well. And then amongst the executive members, there's now about 18 executive members, and these people have a wide variety of perspective on medical cannabis. And other experts in the cannabis space we counseled to bring up the data in this book. Okay, and again, the book consists of, at the very beginning, again, some primers, some background for people who are kind of being introduced to the space. It's meant kind of for people who are introductory, intermediate level in cannabis, but the most important piece there that I'm highlighting are these standardized dosing frameworks, and that's what you're going to get to use today to answer some of the cases. Right? So what do they look like? So just to kind of show you, each chapter is divided into these tables, and these tables here, I'll show you first off, there's phases to each condition. So this is how you would move up with a patient depending on where you're starting. So you'd start at a base and you move up. So for instance, anxiety has a phase 1, phase 2, phase 3, it has a phase 4, 5 in the anxiety chapter. But each phase has on the same page, a titration schedule for the CBD amount and the THC amount. So how you use these tables is, first off, the doses are split by weight. There is rationale to split by 30 kilos. I can talk to that at the end if anybody wants to know, right? So less than 30 kilos, you're using weight-based dosing. More than 30 kilos, you're using just kind of standard set dosing, okay? So with the less than 30 kilos, you're separated into the orange side as CBD. And so this is with your morning dose, your evening dose, and the green side is your THC dose, morning and evening. So these are your dose targets for every single phase, okay? And then when you look at the concurrent kind of titration table here, it tells you what do you start at. So if you're in phase 3 of anxiety, you're going to start with your previous dose, your phase 2 dose, and then you're going to, frequency of increase would be every 3 to 5 days, and here's your amount of increase, here's your dose target, and then some notes there that might be helpful, that are pertinent. Same with the THC on the other side. So every single condition has these phased approaches with set standards that you can follow very easily. And so it's there's that recipe book for cannabis, okay? So again, we're gonna do that, and that's what we're gonna read today when we work through these doses. Something for some people to know that you might not know, conventionally, THC comes first, CBD comes second. So when you see a ratio like 1 to 20, that in the most cases means THC to CBD. Sometimes it's the opposite. So most times authors would put that as the opposite, or they'll state that it's CBD THC rather than THC CBD, okay? So 0 to 50 is 0 THC, 50 CBD, but what does that mean? It really means milligrams per mil. So that's the little metric that allows you to convert between mass and volume when you're doing this. This is the big barrier that really prevents people from kind of using cannabis oils. So again, that's what we're hopeful in utilizing with the tables to help guide people, okay? Because we're just busy. We don't have time to be calculating concentrations. It can be a bit frustrating. The 30 kg rule, as I said, I kind of already showed that, okay? Really the principle, like anything else in any other medicine, is go low and go slow. You go to any kind of drug, that's what you're doing, anti-epileptics, anticoagulants, right? You're essentially doing that, okay? So same principle kind of rides here. Why? Well, does everybody know what the biphasic effect is with cannabinoids? Show of hands, anybody who does not know what biphasic effect is? Okay, so biphasic effect means 2 phases of effect, right? So cannabis is a kind of a tricky drug because at 1 dose and a low dose, it can produce effect A, and if you move up to a higher dose, it can produce effect B. THC is THC for anxiety is a nice example of that, what we might see. Low dose, THC for anxiety can be helpful, can be an anti-anxiolytic. As soon as you go up a little bit, it can actually cause significant anxiety. You go more, it can cause significant paranoia, okay? And can cause actually hospitalizations in that case, and we hear about this. So the biphasic effect is something you have to watch out for, and this book takes that into account. So this is why the go low, go slow is really important. How do you move from one phase to another? Clinically, how would you do that? Again, first principles apply. Just like any other drug, if I was treating a patient with epilepsy with carbamazepine, I'm going to start with the initial dose. I'm going to treat that patient. I'm going to ask them to record your seizures, the severity of them, the frequency of them. Come back in 6 weeks after you reach that max dose and tell me how it's going. If you ever get worse, then tell me beforehand. So they come back after 6 weeks and they say, Doc, that was great. My seizures are down by 50%. Okay, is that a good place for you to be, or do you want to go further? No, I want to go further. So it's a conversation with parents and patients. Okay? And then I would increase their dose. So I would essentially go into phase 2 of the carbamazepine dose. Same principles here for cannabis. Okay, so that's how you're going to monitor how you go forward. Weaning means to steadily reduce. Titrate means to steadily go up. So there's just some terminology for everybody. Okay? Okay, good. So we're going to look at our first case here. So this first case is meant as kind of an example case to work along. And I'm going to show you how to work through a case. And then case 2, headache, case 3, sleep, you're going to do as a team. Okay? So in looking at anxiety, we're going to put this in the context of a child with autism. So here's the case. We have a 12-year-old boy weighing 40 kilos with anxiety in the context of autism spectrum disorder. This child is cannabis naive and is looking at oral dose only. Okay, that's what parents have asked. Currently, the patient's on low-dose risperidone, has tried SSRIs in the past. Other conventional things have been tried, and now the family is asking about this cannabis oil. So when you have a case like this, you want to approach the case in a stepwise manner. You want to think about, how am I going to initiate and with what? How am I going to work this patient up, titrate, right? What am I going to counsel? And if there's a problem, how am I going to take this off? How am I going to wean? So for each of the next cases, that's how I want everybody to kind of think about this when you're challenged with it, and we'll walk through it, right? So just looking here, for this case, some of the key points are what? Well, first off is the 40 kilograms in the child, okay? So that kind of tells us, already I've kind of given you a hint, like, so we have a sense of what, maybe where we're gonna, which row we're gonna use, okay? And then we have to look at this, right? Well, what is the indication? The parents are here because they want to help with the child's anxieties. That's really important. In the consultation, I always ask parents, patients, what is your goal? Right? Because a child with autism might come in, it might be anxiety, they might have aggressive behaviors, they might have self-injurious behaviors, right? So it might be different to target those things. Here specifically anxiety, so if that's the case and you have the book, you would go to the anxiety protocol, and we'd be focusing on that, okay? And then you also want to consider some of the other medications this patient is taking. That might be important, okay? So if you open or you have your resource, okay, so on the resource book, whoever downloaded the QR resource code, or the QR code for the resource book, if you scroll through that, you're going to see those tables I showed you. So each table has a copy of the dosing table. So whoever was the one who snapped that, and it's going to look something like this. So when we look at the pediatric anxiety, so you might want to do it at your table, whoever has that, pop that table up. You can share, or if you got it on your own, then take a look at phase 1 for pediatric anxiety, okay? If you just scroll through the resource booklet, you should see it there. And sorry, everybody at home virtually, I didn't mention this. You should have had links for these two things. So if you're joining virtually, open up that resource guide, scroll down. So here's the phase 1. So again, we are looking at more than 30 kilos, okay? So our target is 15 milligrams of CBD morning and night, and a very low dose of THC here, 0.5 milligrams morning and night for this child. And that's the phase 1 of this approach, okay? How would you do it? Okay, well, here's how you do it with CBD. You're going to start at 5 milligrams a day. Now, importantly, this is 5 milligrams per day, which you're going to split morning and night. So that makes this dose would be 2.5, and this dose would be 2.5. Okay, so that's per day. So just pay attention to the units. And every 3 to 5 days, you're going to go up by 5 milligrams. So, and you're going to try to reach 30 milligrams a day, which would be 15 and 15. So a titration schedule looks something like 2.5, 2.5, 5, 5, 7.5, 7.5, 10, 10, 12.5, 12.5, 15, 15, right? It's long, okay? So do the math on that. I think they're, right, 5 steps, 5 days, 25 days. It takes a month to get the patient there. That's good. You want that. Right? You don't, for me, in my opinion, you don't want to just give the cannabinoids because of the biphasic effect, even with CBD. You might capture a good anxiety response at 5 milligrams twice a day. They don't need to go up any further if that's the case. And so that's an important counseling point, especially on the THC side. So if you look at the THC dosing, okay, 0.17 milligrams per day, so this is where you got to get your calculator and count and do this math. But again, the titration here is slow to get up to that full 1 milligram a day, which is 0.5 split. Okay? So this is, again, the thinking kind of behind this and how you would approach this. So looking at the approach overall, okay, from that table, it's clearly CBD dominant initially, right, with the low amount of THC, and it's titrated very slowly. Why? Again, THC has a very narrow therapeutic window in which it works. Similar to the idea of the biphasic effect, we don't want to overshoot. The worst thing you can do in these cases is overshoot, because then the patient has side effects and they come back, and what do the parents say? Right? Yeah, this doesn't work. right? And that's you did that. You overshot too quickly. You didn't allow the accommodation. You didn't capture the right lower phase, perhaps, okay? So you got to keep that in mind. And in this specific protocol, the THC is split morning and night. Why? Because anxiety is a daytime symptom, okay? So on the epilepsy side, for instance, when you get to the addition of THC, I add that at night first, okay? I do it to see effect, right? Also, you're using bigger doses of THC. So again, there's thinking behind the protocols and why. And as we go to the next two cases, you might come up, you might actually challenge some of them. I'd love that if you did, or you might ask questions as to kind of like, why is this protocol this way? Again, there's rationale based on the evidence, okay? So overall, here's what it is. So the product you're gonna use is a CBD dominant oil, okay? And then you're gonna use a low dose THC rich extract. I like to always separate these things. Why? Because the dosing protocols, right, they're not designed to fit the oils that exist in the market. I never did that. I never dosed people based on that I had access to a 1 to 20 or 1 to 25. As soon as I could avoid that, I avoided that. CBD and THC to me are two different drugs. And you want to be able to move those up and down independent of each other, okay? Again, that's my opinion. I'm quite strong on that as well, but these dosing protocols have that in mind. They also have it in mind so the book can be used universally. A lot of places that don't have THC. So what if you just wanted to use the CBD? That's an option as well, okay? So here again, we kind of started, we talked about the CBD THC, the starting, why you do the 30 kilogram fork, and we also talked a bit about why that is deliberately small, the THC, okay? Okay, so now we're just gonna answer a question. We're gonna move a little bit forward in this case. So now you're gonna answer as a team. So whoever you designated as that spokesperson, that person's gonna be the one who's gonna put the answer in, but you're gonna talk as a team, and you're gonna get a chance to put your team name up as soon as the question comes up. So here we go, okay? So everybody first, it should come up now. You should have an option to put your name in, so put your team name on there. And they should pop up here, I think. So let's see. Nice. Now the Brain Babes, right? Was that yours? Yeah. Good, we got some good names here, all right? 7, there's 7 people at the table, or is that something else? I love the names that people come up with for this. Okay. All right. Anybody not joined yet? All the tables have joined? Okay. All right. Cannabis nerds. Oh, that's great. We're going to have to vote on these names after. Okay. Insert team name here. Nice. Okay. All right, here we go. First question. And there might be a prize at the end of this talk for the winning table. So there might be. Okay. Okay, so thinking of our case, if this child, okay, so now when you're answering these questions, you might need to use the resource guide, just as you know, okay? If the child was under 30 kg and achieved some improvement with phase 1, and you're now considering to move to phase 2, this would involve adding THC. What's the safest way to add THC? So you may need to use the resources, may not. The book that you have at your table now, you can also start looking ahead. You can start jotting answers down. You can start making notes in there because there will be some stuff for the cases for this question, and then for the subsequent cases, you'll have an ability to make notes. Okay, so here I'm going to give everybody. You're going to have 30 seconds to answer. So you've got 28 more seconds to answer. Remember to press send on your device. Okay. Yep. All right. We've got about 8 seconds left, so be ready to submit. 5, 4, 3, 2, 1. Let's see. Okay, so the answer is add low THC dose and titrate very slowly, reassessing anxiety at each step. Okay, so let's see, this is compared to adding a moderate dose for a faster effect or switch to a balanced THC. Okay, let's see. That's the right answer. Okay, great stuff. All right, so I don't know if it's timed or not. It might be. It is timed. So the 3 AGs are in first place. Okay. Okay. All right, it's timed. I didn't know that. It's my first time using Slido. Okay. The people who are virtual, I'm not sure if you can join, but you might try. So I'll leave that QR code up there for just a minute. You might be able to join, but if you are joining, then just say you're a solo team in your name. Okay. So, okay, good. It didn't come. All right. So let's just talk a little bit about the evidence. Like, again, where are these decisions coming from? Why is that? Okay, so this is the evidence in a mix a little bit here. It's the evidence in anxiety, but also mainly evidence in autism spectrum disorder. So what's important is anxiety has never been a primary endpoint in any of these trials, but they certainly looked at it secondarily. And the data is actually pretty good, given what we have, right? And I would say, you know, for me, I might be a little bit biased, but when you look at the quality of the trials, epilepsy, I think, is number one in terms of what's available for us in terms of quality. And I think the autism trials are probably number two in terms of the degree of the RCTs and the quality of those trials that have been created. So, you know, that top RCT up here, if you're looking here, this is, you know, this was a crossover trial, 29 pages, 29 patients, excuse me, aged 5 to 12. This is a CBD oil that went up to 10 milligrams per kilogram per day. Okay, so that can be quite high doses relative to what we just did. But as the anxiety protocol goes up, that CBD dose does go up. Okay, and this anxiety endpoint here was the DBC-2. This is a developmental behavioral checklist, right? And there's a subscale with anxiety on there, and there was a significant result. So in primary social outcome, this is a social responsiveness scale, and this was actually negative in that sense. So some good signal here. And if you look at the rest of the trials here, we do have fairly good signal that you could utilize cannabis in the context of autism. And again, a lot of these trials or most of these trials were used, the 2026 ones unfortunately were not because this textbook was published prior to that, but they were used to inform the dosing tables that you're seeing there, okay? So bottom line for this, as I have here, cautious supervised CBD dominant oil as an adjunct after conventional care would probably be the wise recommendation given that we have kind of treatments for anxiety in the context of autism with better evidence. But for this case, remember, that child had tried a few things, okay? Now, if we were gonna dose up, and this is what you have in the resource book, okay, this is just a summary, you can see this dosing up does go up, okay, on the CBD side, right? And does go up on the THC side, and you can get to, you know, a fairly significant dose of THC, right? But again, you're kind of working through this really slow. So the truth is, if I get to phase 5, even if you get there, this probably would take me about a year of dosing and observation, maybe more, okay? Because you're gonna dose, you're gonna observe, and then you're gonna have the parents come back and tell you. So, you know, but again, I think that is good medicine in the context of cannabis, especially for this situation. Okay, so what about counseling? What are we gonna do, all right? Well, side effects, right, for THC and CBD, they're kind of mostly transient. They can be mild, especially those doses. So somnolence, reduced appetite, that comes from the CBD, okay? Loose stools, that comes from CBD. Vivid dreams and restlessness. Anybody might know why I might have vivid dreams there as a side effect of a combination of CBD and THC? Any table wanna take a guess? REM sleep, okay. So REM sleep, okay, I want to float it. We're going to come back to it in the sleep case, okay? And then again, obviously, in the neurodevelopment, we have to be cautious. So this is a risk-benefit situation in this case. Okay. All right. Well, hold on. Child's on risperidone. Remember, that was the one drug we mentioned. Okay. Any concerns? Anybody in the audience want to answer? Any table want to answer? I'll give you a minute. Minute talk amongst yourselves. Okay. Maybe you can look through the resources. It might help you there. So I'll give you 1 minute to talk. risperidone. Okay, all right. Anybody, you can raise your hand and just say it at your table if you want to grab the mic and make a statement. Anybody here concerned? Is there a concern? Yes, no? If so, what's the concern? No.
No? Yep, there we go. Okay. We don't have an answer to this, but we were curious whether or not there could be a metabolic pathway interaction on CBD and in the same metabolic pathway as risperidone to effectively slightly increase or perhaps decrease the effective dose of how much the patient's receiving risperidone. And are we inadvertently changing the dosing of the medication by administering, co-administering CBD?
Okay, perfect. That should always be the question, right? So if you're new to cannabis or you're uncertain, even if you're an intermediate prescriber, you should always ask that question, okay? There is significant interactions typically with CBD and THC on other drugs or by other drugs, okay? Because they're used in the SIP pathway, okay? I'm gonna show you those, the cytochrome P450 enzyme pathways, which is in your liver, which metabolizes drugs. So CBD and SSRIs have a bi-directional relationship. They impact each other. So you might have to review and consider this. It might be something, okay? As an example, right? Here's an example table. It's quite complex for those that aren't familiar with it, but these are these enzymes, okay, in which sertraline, fluoxetine, and risperidone are broken down or metabolized, okay? So when you see these, right, and they overlap with what we know about CBD, let's say, and THC, there might be an interaction. So CYP2D6 does have an interaction with CBD, okay? So CBD likely increases risperidone levels, but also risperidone can also impact CBD, okay? But this is very minimal, and data so far has shown this effect to be minimal, okay? So I've treated lots of patients, especially with autism, who are also on risperidone. I rarely worry about it, but I think about it and caution. So if a patient comes back and they're having a whole host of side effects, they're overly sedated, let's say, right? There could be dangerous cardiac side effects, as you can see here, so that would be something to consider. But I might take that in consideration. So don't jump at the fact that, oh my God, this child's on THC and THC is making this child sleepy all day. Could be the concurrent medications as well, okay? So again, so important. We have to treat cannabis like a medication. It's a medication, it's a medication. Right? Medication. You would do this with every other medication. You would do this responsibly. And if you don't know that, then you know, if you have a pharmacist or a mentor or somebody else, it's a good person to consult in these situations. Weaning, okay, this is the last kind of concept. You know, really with CBD, you can wean fairly quickly, right? So data shows that you don't really have a lot of rebound effects. So that classic withdrawal typically happens by THC. And I said it twice because that's why I emphasize it so much, right? Okay, so with THC, you do want to usually put through a taper, all right? The textbook has general weaning and titration tables, and we separate those into fast weans and fast titrations and slow weans and slow titrations, because some situations you may need to do it quickly. I just had a patient this week who was waiting for like 2 months to have dental surgery. Kids who have cerebral palsy, they have really challenging you know, oral dental hygiene issues, and they have to go under anesthesia typically to get it done, right? This child also has epilepsy and is on valproic acid, right? So dentists hate to do gum surgery or cleanings or anything in the gums when patients are on valproic acid because you can bleed, right? So the patient was on valproic acid and CBD, and I kind of have to, and they interact a bit. I had to kind of pull them down pretty quickly. Because they got a slot earlier, and you jump at the chance when you can do that for a kid. So again, these are situations where you might have to wean quickly, and so you need to know what to do, okay? When we look for kind of data on side effects and weaning, so you know, in the autism space, So the ARN study, which is an RCT up here, right, with a mixed product, CBD and THC, 28% somnolence, 25% decreased appetite, but no serious adverse events. Okay. In the preclinical CBD data, there really is no there's no withdrawal kind of concern there, no dependence, no reward. That was from some of the Epidiolex stuff. And then crossover RCT, no withdrawal phenomenon was found on the CBD side. Okay. So you can kind of do this safely with CBD. Okay, so here's your summary for a one-pager for the anxiety. So this is what you want everybody to think of as we're going to go to the next case. How do you initiate? How do you titrate? How do you move through phases? What do you counsel? What do you wean? That kind of summarizes everything. And that's in your packet book there, so you have that as a resource. Okay, so as an example, these are where the questions will pop up, okay? So as we're going through this, you can put questions into your phone, okay? So will the slides be available? They probably would be. We could maybe do that. And what I'll do is I'll come back to these questions afterwards if there's anything pertinent right here. I'm just going to answer quickly. If 30 milligrams is target dose, what's 15 milligrams? So that's probably when I was showing the tables. Remember, look at the units. If you're looking at the tables, look at the units. 30 milligrams per day. The first table showed 15 and 15, so it shows you how to separate those doses. And again, I do that purposefully because it's a guide. What if this patient has like significant morning anxiety and night times are okay? You can do like 20 and 10. You could do 25 and 5, right? So that might be a little bit more intermediate or maybe a little more advanced, but the idea is there's some flexibility there to do that, okay? Okay. Case 2, headache in an adult. So now it's going to be the teamwork, and now you've seen how to walk through a case. So, 42-year-old adult, chronic daily migraines, cannabis naive, is interested in medical cannabis for prevention. So the goal is prevention. It's not about aborting an acute attack. Adult is 30 kilograms, so that moves that person to the fixed dose. Okay? So starting the general discussion here, talk amongst yourselves. Right now, what do you need to decide for this patient to start? So you do, if you open up your booklet, you've got a table there, you can make some notes if you like. Use the resource if you want. There might be some information there on headache. Okay, so you can jot things down. I'll give everybody about 2 minutes or so to talk, and then I'll either ask a table or pick on a table. So get ready to maybe say something. Okay, we've got about 30 seconds. All right, 10 seconds. 4, 3, 2, 1. Okay, any table want to say loosely what we need to decide for the patient? And this is a very open-ended general question, right? So any table want to take a stab? Oh, might as well volunteer also. I'm just going to pick somebody. How about this table right in the middle here, looking right up at the front? I think you've got a good answer. It could be one thing. Again, we've talked through this. The idea is I want to get you thinking about this, like what steps. And it really doesn't matter where what type of stakeholder you are in this space. It's good to have an idea of the process. So go ahead.
Can you hear me? Yeah. So we discussed CBD dominant, probably 5 milligrams twice a day, and just go up by 5 milligrams every 3 to 5 days. But at any point, if the patient feels better, they can stay at that level, that they start to feel some relief.
Okay. Would you add THC at this stage?
No.
And why?
Let's see how they do with CBD first.
Okay.
Yeah.
Okay. Anybody else have any other thoughts? Like, think of the case, think of the person, think of what we're treating. Why might we want to just approach with CBD? Well, first off, where do you, I've said it over and over again, where has the dosing protocols come from? They've come from evidence, trials. Trials are built for a purpose, okay? So is the data in trials looking at just like CBD alone for a reason? What are some reasons? Why might that be the case? Why might we have an overwhelming amount of literature that's just CBD and headache?
I believe it could be because the patient is cannabinoid naive, so we want to start with something that wouldn't be too stimulating in that case.
Why might you not want to stimulate this patient? What's wrong with that?
It's preferred to start slow and titrate up, I believe. So I think for at least the migraine, we want to start with more of the sedative or more of the calming effects than the THC side.
Okay. Low dose THC could be very calming.
Okay.
So what are some other reasons maybe why don't we want to stimulate this person? I'll use your word, stimulate. Yeah.
Is it because it has a narrow therapeutic range? So because we're titrating, we don't want to over a long time, we don't want to increase it too much, especially because it's his first time.
Sure. So that could make the person kind of, again, more stimulated. So a 42-year-old professional person, why might we not want to introduce THC during the daytime or at nighttime right away?
I don't know. Not sure.
Why not? Yep. Yeah. Yeah, they're working. This is a working person, right? Look at a child who has anxiety and severe autism. Yes, of course, they are working in their way during the day, but their goals are different. You're trying to control significant anxiety. This person has a chronic pain type condition. They still have to do their lawyering or their writing or their marketing or whatever they're doing, right? So that's just a practical reason. Never mind that when you are doing an RCT, how much easier is it to have a trial that just has CBD rather than CBD and THC? Anybody here has done a trial with THC? Nobody in the room? Yeah, was it hard? Okay, well, I've been involved in a few, and it's a bit more difficult, right, to do that. I'm in hard in terms of getting kind of research ethics and everything approved and stuff, especially if you have two drugs. So again, based on the evidence, but also practically, right? Also, you're a cannabis naive adult. You're coming to see a doctor, and the doctor's like, literally, and I'm being expressive, I'm going to give you weed. That might be what they're thinking, and trust me, some people do think like that. So you're kind of meeting the general population in a very practical way doing this. So again, you have to also think practically when you are utilizing cannabis, right? Again, the worst thing you could do in this situation is to give a person a bad effect, because if they have a bad effect, what are they going to do? They're going to stop using it, and you missed your potential opportunity if you had done it kind of right. Okay, good. So answer as a team. Everybody ready? So remember, pick your spokesperson. So only spokesperson is going to answer. All right. Okay, you should already be on there. I don't think you have to log back in. So get ready. And is it going to go? I think it's going to go. Let's see. Here it is. Okay. So this patient's starting medical cannabis oil for migraine prevention. Which initiating oil and starting regimen fits the headache protocol? So are we going to use a balanced oil, a CBD dominant oil, CBD oil with non-significant THC, or CBD oil with non-significant THC started at 10 milligrams twice daily? Okay. Hi. All right. 10 seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay. So we got a bit of variety answers here. Main answer is CBD oil with non-significant THC start at 5 milligrams once daily. So this is where you have to look through the tables. As I said, be careful, right? What are the units there? Is it 10 milligrams daily split twice, or is it 5 milligrams split twice? Are you reading the tables all right? Let's see. So 75% of the room reading the table as well. Okay, good, good, good. Anybody who answered the CBD dominant oil, remember, we're trying to avoid the THC at the beginning. A CBD dominant oil, by definition, has more than 0.3% THC in it. That's a definition word. CBD dominant extract, we'll have that. Something like CBD isolate, CBD broad spectrum, CBD full spectrum, that terminology will be less than 0.3% THC. Okay? Okay, what do we got? All right, green jays, the green jays. It's kind of how they're playing right now. All right, so they took the lead. Okay, Three Musketeers are in second. Okay, so there's the dosing table, everybody. So you'd use the same logic here, okay? Here we go, 5 milligrams, your target dose. Starting dose is 5 milligrams per day, okay? And so same kind of logic applies here that we saw with the other dosing tables. You would just follow those dosing tables. You've got a copy of it in your resources. So we are initiating with, again, that non-significant THC CBD product, starting at 5 milligrams, building to the phase 1 target. This is a bit faster to get up in this one, okay? This takes just like a couple weeks. We're going to assess for effect with CBD. We're going to add THC later in a stepwise manner. And nocturnal THC is introduced later. Why nocturnal? Again, kind of some of the reasons that we discussed. Okay? All right, well, is everybody aware of last year when at the American Academy of Neurology they presented an abstract on using inhaled cannabis to abort migraines? Show of hands, anybody heard about this? American Academy of Neurology is the biggest neurology conference in the world. Okay, everybody attends that if you're in neurology, more or less. It won the best abstract of all the abstracts. Massive step for cannabis. Okay, their RCT was very well designed, right? So this was a 6% THC, 11% CBD vaporized to abort acute migraines in adults. Okay, so that would be a CBD dominant vapor, right? But this is for aborting headaches. This is not headache prevention. So this is a different kettle of fish, okay? So it's not what we're talking about, but I put it up here because it's important for people to know, because if you're in headache medicine or whatnot, your patients might start asking about this, okay? So again, overall, a lot of the headache data we have that's extrapolated, okay, is secondary outcomes in the chronic pain research, and again, the inhaled cannabinoids are for acute breakthroughs. But you can use oil. I've used oil with headaches for a long time. I think it's helpful for a lot of these patients for a lot of secondary effects that come with headaches, a lot of fatigue, somnolence. So sometimes a little bit of THC can be energizing and stimulating these patients, which are good, and the CBD seems to have an anxiolytic effect. Okay, next question. Okay, another team question here. Everybody ready? Okay. So spokesperson, pull up your phone, right? Okay, so now the patient's titrated to the phase 1 CBD target of 10 milligrams per day. How does the protocol decide whether to go further? Do we advance straight to the next phase, hitting the target? Hitting that phase 1 target means we got to go to the next phase. Add a low dose of THC to augment the CBD. Hold here, reassess only if side effects develop, or observe for the desired effect, then hold if it is reached, or advanced if it is not. What is the best answer here? You've got 15 seconds. Okay. All right. 5, 4, 3, 2, 1. Okay, good. 93% of the room are saying observed. Anybody who said hold here and reassess only if side effects develop, it's not actually a bad decision. You could hold. So I guess it depends. Does the patient come back like 2 weeks later and it's like, oh, it's not working, I got to go. Move, right? If you have space in your clinic or you have the ability to see people quickly, then that might be the case for you. You might want to hold at that point, right? So you do have to have some degree of an observable window to see if there's an impact, okay? But the better answer is have that discussion with the patient. What is your desired outcome? 0 headaches? Half the headaches gone? Weekend headaches gone? And then you kind of meet the patient together and you decide to go forward at that point in time. Okay, very good. All right, the Green Jays maintain their lead. Okay, insert team name here is coming up. All right. Okay. So here's the full titration picture at a glance. CBD goes up all the way to 100 milligrams, okay, per day, 50-50. And the THC is nocturnal. It does end up, and it stays nocturnal, okay? And really this is to augment sleep. Now, you can move THC during the daytime. That would be, I leave it kind of open as not protocolized, but a discussion you would have with your patient. Again, people have chronic daily headaches. A lot of these people do not want to be using THC during the day. And again, data does not support THC during the day for chronic headaches at all. So it's more to kind of like to speak to some of the data that's out there, but also to kind of augment sleep as well. Okay, so I'll just ask this right now because I want to get to the sleep case, make sure we have time. But any considerations in the counseling of this patient? Yeah. Sure.
Why aren't we moving beyond the 100 milligram dosage for daytime?
Okay, so why are we not moving beyond 100 milligrams of CBD in the daytime? The tables fit the best available evidence. So there's, in every chapter, and so I speak to this in the early part of the textbook, we talk about how to approach dosing. How to approach dosing is use these tables. There's a rationale, reason why. Okay, if you get to the last phase of a chapter, you then are into phase X. Phase X is individualized treatment. So if you have expertise, at that point you're kind of doing what you've done and worked for you anecdotally, right? Or maybe there's case series, case reports, other things out there, and and at that point too, if you notice this book does not talk about any of the minor cannabinoids on purpose, right? So at that point you might want to introduce minor cannabinoids or earlier, okay? But again, this book is really aimed at trying to, I was going to say this at the end, but really it's to create some organization out of the chaos. That's the goal of the book. So it's imperfect. It's 1,000% imperfect. And I'm presenting this to all of you to make it better, to make this idea better, right? But it's a foundation to start with. And the other concept that I talk about is the way it's structured is phase 1, you can think of it as like a triangle coming down. Phase 1, the protocols, that's the most amount of evidence. And as you move through the phases, the tables and the dosing protocols naturally become more individualized and less evidence-based, to the point where you're at the very end and now there's like no real good evidence. You're kind of doing what you know or think is best or heard or read about. Okay? Okay. Okay, anything to counsel for our headache patient? No, I'm going to move past because I really want to get to the sleep, but I'll kind of put some points here, right? Few things to counsel that are important, okay? So time course, right? So this can take time for the CBD to actually have an effect, okay? And it's judged over weeks. We're recalibrating the endocannabinoid system. That's the idea with this. We're not looking for that acute, immediate effect. That's a different situation. So again, but headache medicine is like that. Side effects for CBD, right? They're usually very mild, but you have to talk about those. Hepatotoxicity, okay? 100 milligram per day ceiling, right? Is well below liver risk thresholds. I don't know if anybody knows this, but if you look in the Epidiolex data, it's actually really important. There's never been a single case reported of hepatotoxicity less than 300 milligrams of CBD a day in good evidence trials. So this liver is fairly safe until you get to 300 milligrams per day. Okay, not twice a day, per day. Okay, so 100 milligrams per day, you're pretty safe. That might be another reason why we keep it lower. But you do want to monitor them regardless. So I do blood work on these patients. Look for interactions with other drugs. If we have to wean, there's a weaning table for you, and that's roughly how you would do it. Okay. Okay. This is kind of some evidence in terms of safety and stopping. So what we have here in headache studies, okay, the adverse events, and this is 32 patients. Adverse events mostly mild, 44%, no serious adverse events. This is fairly consistent across the CBD literature, especially at these doses. In this one here, this is headache tolerance and overuse. So this can happen here, so you certainly can get tolerance and overuse, so pay attention. The UK registry has looked at kind of mixed formulations. So again, overall, there's no oral oil for headache trial that exists, okay? We actually tried one in kids, and that's going to be published soon. It's called the Cantrell trial, but we got a fair number of patients. But in the end, it really couldn't reach an endpoint because of a lack of recruitment. It was a very difficult trial that we put together that failed in the recruitment phase, unfortunately. So that should come out soon. Okay, so there's kind of your one pager. You're initiating titrating. That's your ceiling. Here's the nocturnal THC, which comes in later. Counsel on the slow onset. Liver enzymes, interactions, and reverse the titration. Make sure if you're going to taper the THC, you do it really slowly if you get to that point. Okay? Let's skip the questions just for now because I want to get to this last case with the last few minutes that we have. So we're going to look at sleep after concussion. Okay? What do we do in this situation? So here we go. We've got an adult with persisting sleep disturbance after a concussion. So this is not after an acute concussion. Sorry, I'm talking about. Okay, so we're like 3 to 4 months out now. Okay, so it's persisting symptoms after concussion, right? This patient's cannabis naive, has tried other sleep agents like trazodone, either no longer working, minimal effect, or has experienced undesirable side effects. Is cannabis an option? So what does the sleep protocol indicate for dosing? So mostly, again, this is going to be in your notes, THC is the primary agent here and is given nocturnally. Okay. CBD is added later to kind of support the tolerability of THC because there is some supportive data, especially anecdotally, where adding on CBD can kind of bring down the side effects of THC, so patients can accommodate more THC if CBD is present. Okay? So that might be a way to introduce daytime THC if it's needed in other situations. Okay? What do we need to consider outside of dosing? Well, in this case, given that this is primarily THC, you've got to think of THC-related side effects. And then what happens if the side effects become intolerable? What do you do for these patients? Now, what's really important is if you've worked with this post-concussion population or know about it, I think there was just a talk right before, they're very sensitive to medications, okay? So this is a bit of a nuance to this case here, right? Very sensitive. They will tell you their nervous systems feel hypersensitized, and they'll say that. So, and they can have these vestibular, these balance issues, and they can have cognitive symptoms. So we got to be a bit careful here, okay? Okay, so in this case here, we've got the steps we would go for. So if you look at the protocol, it's a THC-rich extract you're going to start with, given at night, right? I say here ideally containing myrcene, because myrcene has, again, some data that says it supports sleep, right? So why not if you have access to it, okay? So that's a little bonus. You could do that for people that don't know. Again, myrcene is a terpene. It's not a cannabinoid, right? But it comes within the cannabis plant, and a lot of oils will tell you their terpene profile. Terpenes give the color, smell, flavor of a plant, okay? The aroma of a plant. So myrcene is one of those, and it can impact sleep. It can positively impact sleep, perhaps. Start a low dose, 60 to 90 minutes before bed. Allow a 5-day window before titrating, okay? You really, minimum, you want to allow that. Why THC dominant? It's sedating at low dose. Okay? CBD actually at low dose is not sedating. Okay? So we kind of avoid CBD here, right? And it's added later, again, just as the THC dose climbs, we add the CBD to mitigate against those side effects. So why are we choosing an oil over inhaled formulation? So I'll give you a minute to talk in the group. Why am I up here saying like, and I would stand by it, I would say oil for sure before inhaled. So talk amongst yourselves for a minute, and I'll ask a table or two. Okay. Let's hear from a table we haven't heard from. Who wants to volunteer? What table? Right? Oh, there we go. We got a hand. Yeah. Longer lasting. Good. Okay. So a longer lasting effect.
Be active in the body longer than an inhaled formulation.
Perfect. I think it's a great answer. Yeah. So there's a longer duration of action for an oil over an inhaled product. That is true. Right? Those dose curves you see, inhaled goes up right away and comes down. Oil kind of doesn't go as high, but it lasts longer before it's metabolized out of the body. Okay, good. Any other reasons? Yeah.
Accuracy in dosing?
Beautiful. Accuracy in dosing. Okay, so accuracy in dosing. What parameters might impact accuracy of dosing when you were looking at inhaled versus oil? What kind of things? And anybody can, yeah. Cool. Yeah, how long the product's been on the shelf? Great, so that's important. But would that go for both oil and flower?
Yes, for flower more so. You also are doing you can buy a bag and whatever it says on it. It doesn't mean that all the flower from that way to that exact amount.
Okay, good. So shelf life's important, product content's important. Yep.
When you're inhaling, everyone inhales differently, exposed to differently, so the consistency of that. So it's not kind of a parameter there. So everyone doesn't remain the same on the inhalation, so we get direction.
Yeah. Perfect. So the method of inhalation, really important, right? How deep are you inhaling? How much are you inhaling? How hot is the vaporizer? What is the quality of the paper? And if it's a joint, let's say. Good. Okay. One more big factor that comes in. It's kind of related to that. Yep. Yeah, true. So smoking, there's just prohibition where you can smoke. It's much easier to take an oil. You take it to work. You can, right? Exactly. More just thinking anatomically, the size of the lungs, right? So how on earth can you dose people, right? It's really a challenge. You can't really control it. And again, I think kind of the emphasis I've been saying to everybody here, it's control. Take control of that dosing. You can't really do it, okay? So looking at kind of THC oils containing sleep. So ultimately, what is the data showing? That there's benefit for THC, okay? Largely, they tend to be subjective. So patients in these trials feel better. They report qualitatively their sleep is better. They feel more rested, but kind of the measures or the sleep scores and things like that aren't actually translating, okay? And there's one, this is a really good study. This is an interesting one right here. Came out in 2025. This was a single oral dose of 10 milligrams of THC and 20 milligrams of CBD, okay? And it actually worsened sleep for these individuals. I never ever treat sleep as PRN, means as needed. I think that's probably the worst thing you can do with sleep. People are really critical in their time. If it's a time zone, you can treat them for like a few days perhaps. But for somebody to have like, you know, a bottle of Ativan or Trazodone or Imovane or whatever they're using and to just kind of use it whenever, you're making sleep worse. So again, these protocols, the idea is if you're thinking sleep is going to work for cannabis, you're thinking the endocannabinoid system is kind of, you know, it's miscalibrated for a reason, and you're supplementing it to bring it back into a degree of balance. And so that's going to take time and low doses overall, okay? So looking at the sleep protocol, right? It's just THC. You get to 5 milligrams in the first day, start 2.5 milligrams at night, next 5 days go up. So you're up pretty quickly, and you want to monitor for a bit of time here, okay? You can extend that if you want. Again, these are guides. So the full titration at a glance, what do we do? Okay, so on the THC side, ultimately you're getting to 15 to 20 milligrams at night. That can be a very big dose, okay? I very rarely get there with a patient, okay? But if you're doing this very slow over time, you're going to capture, it depends on the number of patients that you treat, you're going to capture the people who seem to just be able to tolerate very high doses of THC. That probably has a lot to do with their biology and their genetics. So this phase moving forward like that is typically for that. Normally by kind of like 10 milligrams, 12 milligrams, if you're not getting an effect on sleep, you know, probably not going to get much more. And the CBD comes in around that 10 milligram mark to balance and allow, hopefully, to mitigate the side effects of the THC, to reduce the daytime grogginess the next day, maybe the high feeling, some people might not like it. So the introduction of CBD here, kind of at a low dose, does help. The intention there is to mitigate against that. Okay, so we've got 5 more minutes. I think we'll be able to get to the next questions. I'm going to get through them, okay? So here we go. This is a team answer. Patient on nocturnal THC oil for post-concussion sleep, for a few weeks reports daytime grogginess and that their attention and memory feel worse. What's the best next step? Do we increase the THC dose to deepen sleep, reduce the daytime tiredness, add a small morning dose of CBD to counteract, reduce THC dose and confirm it's taken 60 to 90 minutes before bed, stop the oil tonight and start a nightly benzo? Okay, 5 seconds. I'm rushing people a little bit here. Okay, let's see. All right, so yeah, we want to, if that's the case, we're going to reduce this, okay? So again, this could be a discussion. Could we add a small morning dose to counteract? Maybe, but that's not by the protocol. So the protocol is not just to add a morning dose of CBD. If you were going to do that and move to the next phase, I'll follow the protocol. There's a day and a night dose of CBD, and it's not just a random small amount. That's the whole point, okay? It's a protocolized amount. You want to be protocolized. You want to be standardized, okay? So 77%, what do you got? Green Jays maintaining their lead. Okay, oh yeah, they are. Okay. Oh no, it's Buds, sorry, Buds. Buds has come up. Okay. So rapid fire through the last cases because I really want to get everybody to the end here, okay? Here's what we would counsel people. So the expected side effects of THC, okay? There's cognitive effects. We talked about kind of the upper dose. So really the management is you want to reduce the dose for daytime sedation if that's the case. Make sure it's 60 to 90 minutes before bed. Avoid other sedatives. Cognitive behavioral therapy and, for insomnia in parallel, always, always, always. I never look at this as going to cure their insomnia. I tell patients this is just a tool that's going to help you develop the skills you need in order to combat your insomnia or to fix your insomnia and your habits. Okay, here's another question. All right. This is a long one, okay. So you're managing medical cannabis for a busy lawyer who has used nocturnal THC oil for post-concussion for sleep for about 3 months, reaching 8 milligrams at night in phase 2. Effect has been minimal. She's experienced side effects of grogginess and cognitive slowing that was reduced with taking the oil earlier at night and going to bed earlier. She now wants to come off due to the lack of effect. What's the best approach? Okay, so to be stopped abruptly and manage rebound insomnia if it appears, taper gradually, warn about insomnia, continue, switch to a nightly benzo, recommend attempt to move to progress to the end of phase 2. A study showed effects of THC once you get to 10, then make a decision to taper if there's no effect. Move to phase 3, adding CBD, increase in THC exactly as per the protocol with the idea that CBD might counteract the side effects, make THC dose more tolerable, and have a positive impact on sleep. So this is the toughest question. This is going to be the differentiator. Okay? All right, 5 seconds. It's okay. You like 3 more minutes? Okay, 5 seconds. All right, 4, 3, 2, 1. So we've got some people saying taper gradually, warn about rebound insomnia, recommend the attempt to move to progress to end of 2, move to phase 3, and the answers are, all 3 are answers. Okay, good, you guys are learning so much, I'm so pleased. Nobody said anything else, this is awesome. Yeah, so this is so important, I'm going to emphasize again, this is the discussion with your patient. All of those pathways are legitimate based on the clinical situation. You just have to talk to your patient and figure out and decide, what do you guys want to do together? Okay, very good. Awesome, everyone. Okay, let's see. Oh, saying that you didn't get it right. Oh, maybe you had to answer all 3. Okay. Yeah, it was multiple. I thought it was going to just give like either, like or. I didn't know you had to do and. Sorry. Anyway, all right. Honor system. Did Buds, did you answer the right one? Okay, all right. Okay, I got to know for next time. Wean the tolerance is a rebound and the rebound drop. Okay, so the biggest thing here that I want people to know, okay, is be very careful with THC, okay, because you can develop tolerance and their insomnia can come back. And then you can say, oh, I'm going to give you more. And they develop a tolerance and insomnia, I'm going to give you more. And they're not doing their CBT. They're not changing their habits. So just be very careful that you're not treating a withdrawal. Okay, so you've got to have a good communication. Does that make sense, what I'm saying? Is everybody? Okay, good. And so what I do with this is I set a course. I set, this is a goal. Sleep initiations, okay, we're going to work on this. This is going to be your tool. You're going to work for the next 3 months. And when you come back, I want to know about what changes you've also made in addition to this, because you don't want to leave them on this for a long time. And that's just a principle of sleep medicine with any of these medications. Responsibly, that's how you would use some of the Imovane, like I said, or some of the others, okay? Evidence is there. I just want to get to the last here. We kind of talked about the thing. The last thing is, because I mentioned it before, vivid dreams. So THC suppresses REM. So in withdrawal, you will have REM rebound and you can have the wildest dreams. So they might come in complaining of dreams. That would help you understand that they're in a withdrawal. Or if you're or you're weaning too slowly, you could bring these out in a patient and they can actually be quite disturbing, the dream sometimes. So be warned of that. Okay, that's the end. We're going to go back to the last 3 questions. Let's see our knowledge gain and then we're done. So whoever took the pictures initially, you can let us know if we've gained knowledge. So you're answering on your own. So everybody grab your phone to answer on your own. Let's see how much you've learned being here. So can you, we'll do the answers first and then we'll compare. Okay, so the first question is, oh, it's up here. Oh no, someone's already answered maybe. I don't know. Try that. Is it working? Like I said, it's the first time I've used this. This is a test run, we'll see. So for a patient who's interested in trying medical cannabis for headache, what approach should be taken? Yeah, I think this is just current answers. Oh, no, I think it did show the answer here. Okay. No, it didn't. Okay. Okay, so this is active right now. Where we're going, we'll do this for another 5 seconds. Okay. 4, 3, 2, 1. So this is for cannabis for headache. So we've got 94% saying answer 1. What was our percentage in the beginning? 41%. Okay, good. All right, that's awesome. Okay, next. Okay, when weaning a patient off THC dominant oil used for sleep after concussion, what's the main risk to anticipate? Oh, I guess people, you can answer them all together, right? Right now? Okay, good. So, all right, so we've got 84% rebound insomnia, disturbed sleep. 58% initially, okay. Fantastic. And now the last one here, we got 94% saying CBD dominant oil with low dose THC, cautiously titrated slowly. What was our? 76. Okay, this is fantastic. So key learning points here, I think most of the room has hit it. That's for each of these disorders, right? And then overall, last slide, principles to take away, okay? Dose by indication, right? Very important. This is what I think people should do. This is how the book is built. This is what I've been doing for a really long time. Go low, go slow, biphasic effect. Counsel and screen. I think that came up enough where you see that's important. There's contraindication, interactions, and you've got to be honest about the evidence with patients. Wean, right? So be careful. THC requires a careful taper up and a wean down. Don't forget about CBD. If you're using CBD in epilepsy, weaning any medication for seizures can cause rebound seizures. You must wean CBD slowly, okay? That's the only caveat. And again, answer the evidence honestly. There's no strong condition that's specific. I think the buds one, were you guys number one? You were? Okay. Congratulations to the winning team. Write your emails down. Come see me after. I'm going to get you guys a hardcover copy of the book. Okay? So, and for everybody else, if you want the PDF version, it's online. You can get it. It's a super easy download. There's the discount code, so grab that. And thanks, everybody. Thanks for running through this with me today. Hi.